Hi everyone, let's talk about HIV and AIDS. So HIV stands for human immunodeficiency virus. It is, as it says, a virus. AIDS is a syndrome, acquired immunodeficiency syndrome. AIDS is the progression of HIV. This virus attacks the immune system, especially cells that have CD4 receptors on them, and because the helper T cells have lots of these receptors, they are particularly affected. The pathophysiology involves how HIV gains entrance into the cell, replicates itself, multiplies, and then eventually causes death of the T cell. Epidemiology, HIV and AIDS probably started in the early 1900s, spread across Africa and eventually to the rest of the world. It's believed to have evolved from the simian immunodeficiency virus, which crossed the species barrier from primates to humans somewhere in Central Africa, most likely when human hunters came into contact with infected blood. The primary HIV strain, HIV-1, has been traced to chimpanzees. The less virulent HIV-2 has been traced to the sooty mangabe. Might be saying that wrong. The CDC estimates that there have been almost 80 million infections since its inception, 36.3 million deaths, and currently 37.7 million people are living with HIV. The CD4 helper T cells are very important. They're a white blood cell. They play a central role in the normal immune responses by producing factors that activate virtually all the other immune cells. So once they're activated, then the helper T cells trigger the release of cytokines, cytotoxic cells, macrophages, and even B cells. So without them, we wouldn't have a normal immune response. They are important to adaptive or acquired immunity, and we're going to talk more about immunity in the next video. Damage caused. Well, first, so your helper T cells, you just keep making them. They, over and over and over again, we make them, and we make an attempt to fight the virus off and still maintain an immune response. But eventually, the damage caused by the HIV, by the virus, eventually is going to destroy more helper T cells than the body can make, and that's when we have the appearance of opportunistic infections. And opportunistic infections are one of the diagnostic criteria for AIDS. So here's a picture of the virus. HIV is a retrovirus. A retrovirus is defined as a virus that uses RNA as its genomic material. It also can't grow or multiply without a host cell. So inside the cell, well, first off, this virus has an affinity for the CD4 receptors, like I said earlier. So on the inside of the cell, there's 3 enzymes and 1 DNA or RNA strand, and this is what the components that do all the work to get the cell into the helper T cell and eventually kill it. But we have the reverse transcriptase. Let me see if I can find a pointer. Reverse transcriptase right here, and then we're going to talk about the protease, which is here, and the integrase, which is here, and then this is the DNA strand. Also want to point out that the outside of the cell is surrounded by glycoproteins, and so this is what is referred to as the lipid envelope. And this particular one here, GP120, the GP stands for glycoproteins. This is an important because it's needed in order for the virus to be able to attach to the CD4 receptors. So we'll talk more about that when we talk about treatment. All right, so to understand how HIV progresses and its treatment, we do have to understand the life cycle. Treatment is based on interrupting some part of this life cycle. So you can see in the upper left, you can see the HIV and it's those internal components we talked about. They're not all labeled here, but reverse transcriptase, integrase, and protease, and then the single strand of DNA there. So the first thing the virus needs to do is to attach itself to the CD4 receptor. right in here. And then it gains entry into the cell with the help of these things called co-receptors. And these are the co-receptors right here, CCR5 and CXCR4. So we need to have that glycoprotein 120, which attaches to the CD4 receptor on the helper T cell. But in order to get into the cell, it's got to also have these co-proteins. And once it enters the cell, it's going to deposit its cell contents into the, I can't see my screen here. Guess I don't actually have to. Anyway, once the virus enters the cell, it's going to deposit its cell contents into the helper T cell. So first of all, it looks at the reverse transcriptase. This turns the RNA into a double-stranded DNA. The DNA then moves into the nucleus and releases that integrase. The integrase facilitates the excuse me. The integrase facilitates the integration of the viral DNA into the cell's DNA. And at this point now we have the virus, which is in control. It's taken over the helper T cell. The new DNA then produces these long viral proteins, and these begin to assemble and make the new cell. And it pushes its way towards the surface here, and it buds out. That's called budding, and then it actually just breaks off. And so once it pops off, the final enzyme, which is protease, is released, and it helps the cell to mature. It also has a role in killing off the helper T cell here. So that is the viral life cycle. All right, transmission depends on several factors. The viral load, of course, of the infected person. The higher the viral load, the higher the chance of transmission. And when you're in the acute phase of HIV, right after you contract it, you have a very high viral load, so you can transmit it easily at that point. ARTs, which we'll talk about, that's antiretroviral therapy, can decrease the viral load and the risk of transmission. The type of contact is also important. Unprotected sex carries a greater risk than you just having a needle stick from a patient who has HIV. Healthcare workers who are exposed to HIV positive blood have a 0.23% risk of becoming infected, and that's from the 2015 statistics. So even if you are stuck with a contaminated needle, which there's many safety strategies in place so that doesn't happen today. But if you are, the risk is low. The immune system of a person is also important. Some people just have super strong immune systems and can be exposed and not get infected ever. For transmission to occur, HIV needs to be present in these fluids: blood and blood products. So that includes, all of your platelets, your fresh frozen plasma, all the blood products, including RhoGAM, semen, vaginal fluid, breast milk, central spinal fluid, pleural fluid, peritoneal and pericardial fluid, amniotic fluid, and any fluid that's contaminated with blood. So these fluids need to get into the bloodstream to affect the host, or they can enter through a mucous membrane. And mucous membranes are found in the mouth, the penis, the vagina, and the rectum. Also, it can enter through open cuts or sores, or you can directly inject it with a needle. So it can enter the bloodstream directly or indirectly, and indirectly would be through some kind of an injury. So if you have a sore on your lip or a sore in the vagina or the penis or the rectum, it can enter through that injury. There are activities that increase transmission of HIV. We all know unprotected sexual contact is one of them. So when you're teaching your patients about condom use, you need to teach them that condoms should be used from start to finish and 100% of the time. Drug use, so needle sharing, or just using contaminated needles. Having received a contaminated blood transfusion, needle stick injury, non-sterile tools, so those that are used for tattooing, and then during pregnancy. And pregnancy includes when you're during the pregnancy, during the labor and delivery process, and also during breastfeeding. So if you have an HIV positive mom, you would not, even if she was on ARVs, you would not encourage her to breastfeed, which is kind of a bummer in like third world countries. I used to go to Haiti a lot, and there's a lot of HIV positive people that live there. And so they don't have formula, access to formula like we do. And so they still breastfeed their babies, even though they're HIV positive. My little marker's not working here. All right, HIV is not contracted, though, through hugging or closed mouth kissing, coughing or sneezing, sharing cutlery or crockery, bed linens, toilets or showers, touching clothes, objects and hands, through mosquitoes and insects, through tears, sweat, or saliva unless it's contaminated with blood, or through any form of casual contact. There are 3 phases involved in the progression of HIV to AIDS. Stage 0, you'd be at stage 0 when you first contracted the infection. And then stage 1 is your CD4 count is over 500 and your CD4% is over 600. So the CDC percent can indicate whether the patient is having a real change or just a fluctuation, because remember, your CD4 count is going to respond to any type of infection. So you can have a low CD4 count just because you have something else going on. So you don't see the percent ordered very often, but occasionally it is. The percent is just generally more stable, so it won't be affected by fluctuations. The CD4 count itself is still best at predicting the progression of HIV. So stage 2, we have a CD4 count of 200 to 499, and there's still no age-defining condition. In other words, the patient still has not experienced any opportunistic infections. And then when we get to stage 3, this is when you have AIDS, and you have opportunistic infections, and your CD4 count is below 200. So basically, if we were to label these, it'd be acute, chronic, and AIDS. So let's talk about the acute phase just a little bit. It usually begins 2 to 4 weeks after becoming infected, and you can see before infection here, and then the acute phase, you can see all the little red dots those represent the virus. So you can easily spread it to others in the acute phase. The viral load, like I said, is really high. You may get symptoms like you would with the flu, so GI upset, fever, joint pain, aches, swollen lymph nodes, headache, fatigue, sore throat, those kinds of symptoms. Testing, there's no test that shows immediate infection. So until you actually start making antibodies, that's the point when seroconversion has occurred, and that's when you'll pick up the antibodies. So you won't be able to pick up an infection 3 days after you have a high-risk exposure. The chronic phase, this is also the asymptomatic phase, sort of like with syphilis. You have that long latent phase. The viral load is lower, but the virus is still active and still replicating, so it can still transmit. CD4 count is 200 to 500. You do not have any opportunistic infections present. And this stage is going to end when the viral load increases, the CD4 count lowers, and you have some type of opportunistic infection. The late stage is AIDS. The immune system is just destroyed by the virus. The viral load is very high, and you can see that from the image here. Without medication, the survival time is just a few years, which is why in the 80s, before we really knew what we were dealing with and had no antiviral treatment to offer, they passed away fairly quickly. So the diagnostic criteria is below 200, or they have the presence of an opportunistic infection. So even if your CD4 count is 300, if you end up with one of the opportunistic infections, you've fallen into the AIDS stage. All right, HIV testing. So antibody tests look for antibodies to HIV. So that occurs after seroconversion. Looks for it in a person's blood or oral fluid. Antibody tests can take anywhere from 23 to 90 days to detect the HIV after exposure. The most rapid tests and the only FDA-approved HIV self-tests are antibody tests. So if your patient goes to the store or orders an HIV test online or something, he'll be getting an antibody test. So you just have to let them know if they get a negative test and they've been, 1 month out from exposure, they should retest again after 3 months. In general, the antibody tests that use the blood from a vein can detect HIV sooner than the tests that are done with a finger stick or with the oral fluid. The antigen antibody tests look for both HIV antibodies and the antigens. So if a person has HIV, an antigen called P24 is produced before antibodies. So you're going to pick up the antigen before the antibodies. These tests are recommended for testing done in labs, and they're the most common ones done in the United States. A venous sample can usually detect HIV between 18 and 45 days after exposure. There's also a rapid antigen antibody test that's available and is done with a finger stick, which can take 18 to 90 days after exposure to have a positive result. Finally, we have the nucleic acid tests, and these are looking for the actual virus in the blood. So this test is considered for people who've had a recent exposure or a possible exposure with early symptoms of HIV and have tested negative with an antibody or antibody antigen test. It can usually detect HIV 10 to 33 days after exposure. It's not the most common test used. They are sort of expensive. When I looked this up to see if there were multiple types of nucleic acid tests, there are 3 that have just recently been approved, so it makes me think we may see nucleic acid testing being done more frequently in the future. So the CD4 count, we're measuring that all the time. So this is measuring the number of helper T cells. So the normal count is 500 to 1500 cells per millimeter, and less than 200 or progressing to AIDS. Sorry, I said that wrong. If it's less than 200, you are showing progression to AIDS and a risk for opportunistic infections. So as a nurse, you just need to realize those low CD4 counts mean they just do not have the immune system to mount a response to any type of pathogen, even the ones that we normally keep in check. And we'll go over those opportunistic infections in a second. So antiretroviral therapy is started as soon as possible. So as soon as you get a positive diagnosis, you're not waiting for it to progress or waiting for symptoms to show up. And we do this because it can lower the viral load, it lowers the risk of transmission, and it lowers the risk of opportunistic infections. And that brings us to opportunistic infections. So in the malignancy category, we have a Kaposi's sarcoma. This picture right here is a Kaposi's, and they're just kind of like purplish violaceous in color, and they almost looks like a basal cell. It has this rim around it and a kind of a central cleared area there. They're thick, so they almost look like what a lesion would look like in someone, like a cutaneous lupus lesion kind of looks like that, very distinct. Viral infections, so cytomegalovirus, CMV, this has, oh, I didn't do, so this has can appear actually in the lungs, the brain, the GI system, but most significantly, I have an error there, sorry, it shows up in the eyes and causes blindness. And I had a friend that I went to high school with, and he contracted AIDS in about 1983 or 4, no treatment, and he died about 1990 or 1991. And he went through everything, had all of these, and before he died, he had CMV, and he quickly lost his eyesight. Epstein-Barr virus, one of the hallmark symptoms of that is this down here, it's called hairy leukoplakia, and this is white patches, kind of thickened patches that are on the tongue. They don't scrape off, you can't, wipe them off. Remember, fungus usually, not that fungus can't occur with these patients also, but we'll see that on the top of the tongue. But these we usually see on the sides. And then herpes simplex type 1 or type 2. So that is going to, if you've had herpes before, you know that just sort of rests in a nerve ending and can pop up whenever you get stressed or anything. So those can happen quite easily, but also they happen in people who have never had an herpes infection. Lots of bacterial infections. So we have the Mycobacterium tuberculosis, which we know is spread in the air. It also can infect not just your lungs, but the brain as well. You can even have TB lesions on the kidneys, so it can spread. So what can happen with this that makes it kind of interesting is you guys all get TB skin tested every year, and you have to, submit that. And you will always have to do that. But if you test positive, then you get I think it's now a 3-month treatment with an anti-tuberculin drug. And that's in the hopes of just, eliminating your chance of actually getting an active infection. But a lot of people have been exposed. They may have started to get an infection or had a mild infection and in the lung, and then it will just wall itself off. And so it's just there, but it's never going to cause you any problem until you have a diminished immune system, and then it can reactivate. So chemotherapy can do that, but most certainly, some medications, if you have a kidney transplant or something, anything that can diminish your immune system. But of course, HIV/AIDS is common. Salmonella, so a lot of foods have caused salmonella outbreaks, peanut butter, packaged meats, frozen food, and produce. I'm just going to give you another example of in Haiti. They make their own peanut butter. So just like on the street corners, they just grind the peanut butter like the Indians used to grind their masa, just with flat stones. And so, of course, there's no preservatives or anything. But when I was there once, they had a salmonella outbreak, and they traced it to the peanut butter. And because they had so many HIV positive people, it was a terrible outbreak. But here in the United States, it's reported, and usually we have recalls on packaged foods. And then Mycobacterium avium complex bacteria. This bacteria is in the soil and water, and so it can cause Mycobacterium avium complex lung disease in older people or those with weak immune systems or previous respiratory problems. So this is, because it's found in soil or water, we don't see it a lot, but you do consider it when you're taking care of the AIDS patient if they end up with some kind of a lung disease. Strep pneumoniae, that's the most common cause of pneumonia, which is when your patients get the pneumonia vaccine or the pneumovax, this is what they're getting, the this is the pathogen it's hoping to keep from making you sick. So it's common, but it can be deadly in people that don't have the immune system to deal with it. Fungal infections like candidiasis, so that occurs in the mouth, the vagina, the lungs, can also occur in uncircumcised men, so they can get what's called balanitis around the penis if the foreskin's not pulled back. Coccidiomycosis, that is valley fever. I think we're pretty aware of valley fever because we live in Arizona and we see this on occasion. I'm going to say this right. Cryptococcus. I don't know. Cryptococcus. That's how you say it. Anyway, it's a pulmonary It's a pulmonary disease, but it also can disseminate to other parts of the body, and it's also found in contaminated soil. And this is kind of a yeasty type of fungus. And then histoplasmosis, the fungus lives in the environment, particularly again in the soil that has large amounts of bird or bat droppings. And then pneumocystis pneumonia. So pneumocystis pneumonia also is known as pneumocystis, and people say this many different ways across the world, but I heard it pronounced, it was like Harovecki or something like that. Just remember it starts with a J-I-R. Anyway, this is a form of pneumonia that's also caused by a yeast-like fungus, and this is one of the opportunistic infections that HIV patients tend to present with. Then we have the protozoal pathogens, and so toxoplasmosis is an infection that we get from a parasite called Toxoplasma gondii. People often get this infection from eating undercooked meat. So when you're teaching your AIDS patients, HIV positive patients, how to stay healthy, you want to make sure that they're eating well-cooked food. So that would kind of eliminate like sushi or rare meat. You can also get it from contact with cat feces, and this parasite can pass to a baby during pregnancy. So you see this when you're studying your OB patients, that toxoplasmosis is something that an infant can be born with if the mother contracts it. So that's why we're telling pregnant moms, to not change their cat litter. And then we have cryptosporidiosis. It's an infection that causes diarrhea. It's caused by a parasite again. Most people get the parasite after swallowing food or water that's tainted with stool. And then schistoisosporiasis, I think. Schistoisosporiasis, close enough. It's caused by an obligate intracellular protozoa that infects the intestinal epithelial cells. So transmission is going to be by the fecal-oral route, like your hepatitis A, or food, contaminated food and water with feces from an infected person. So lots of opportunistic infections. Preventative measures, there's an acronym that a lot of people use called WEAKEN. So I'm going to use it here too. The W is for water consumed should be from treated sources. E is eat foods that are not raw or undercooked. A is avoid risky sexual behavior and drug activity, risky drug activity. K is to keep vaccinations up to date. E is for exposure to animal feces. N is for need to take the ARTs. So in terms of screening, your role is to know who gets screened for this and encourage patients to do so. So anyone who engages in activities that will put their body fluids or fluids in contact with someone else. So if you are in one of the high-risk groups, you're men who have sex with men, IV drug users, and these people who are high risk are typically very educated about this, and they will self-refer for screening or do their own tests, but not everyone, especially the IV drug users. So when you're doing your assessment of your patients, you're asking them about sexual behavior, drug use, history of sexually transmitted infections. If you have one sexually transmitted infection, you are at higher risk of getting a second one, and AIDS is an STI. And if anybody had blood transfusions before the year 1985, so in 1985 we were able to isolate this virus and keep it out of donated blood. So testing, it should be annually for those at high risk, and the U.S. Preventive Service Task Force recommends at least testing once in ages 13 to 64. That's a very vague recommendation. All pregnant women get tested for HIV, which makes perfect sense since we can treat it. You want to educate them about the disease, so knowing after exposure when it will show up, when to get tested, and the early transmission, of course, also how it's transmitted, because people are confused about that, and then the use of antiretroviral therapies. And monitoring labs, so monitoring the CD4 counts, the progression that can occur, just naturally it can progress, or the ARTs can keep it in check for many, many years. And then they should understand about the opportunistic infections so they know what to watch for. When you're teaching about transmission, you want to teach them to limit activities that can transmit the virus. That's obvious, but you do need to go into that specifically. So talk about prevention, using clean needles, using condoms 100% of the time, taking care if they have a new partner, a new sexual partner, to make sure, both of you are healthy. Partner notification, if you do test positive. HIV is a reportable STI, so the health departments get notification of this, and then on the notifications there's a space where you have to write in who the partners were and if the partners were notified. It sounds like such a breach of confidentiality, but it has to be done. And then pregnancy, so if your patient is pregnant and they're HIV positive, they need to be started on the ARTs as early as possible. And this has been a pretty dramatic finding, because there's less than 1% chance of transmission to the baby if these meds are taken early, and if the newborn is treated for 4 to 6 weeks. So there have been cases, where they have no viral load whatsoever when they're born or in their first year of life. So you can keep the baby from getting it, which is a big deal, which is why everyone needs access to the ARTs. So the goal is to limit the virus's ability to replicate by interfering with parts of that HIV life cycle, and to decrease the viral load within 6 months. So once you start it, you should see a measurable decrease in the viral load within 6 months, and an increase in the CD4 levels to above 500. There are 6 drug categories. So we've got attachment inhibitors, entry inhibitors. So the attachment inhibitors will keep the glycoprotein from being able to attach to the CD4 receptor. Entry inhibitors, we have those that actually keep the virus from being able to enter into the cell. Integrase inhibitors, protease inhibitors. We have nucleoside reverse transcriptase inhibitors and nucleoside nucleotide reverse transcriptase inhibitors, and we'll take a quick look at each of those. So the attachment inhibitors bind to the glycoprotein 120, so right in there, this glycoprotein, those little things there, and it keeps them from attaching to the CD4 receptors, like I just said. Or they can bind with the CD4 receptor and inhibit this GP120 from being able to activate and engage with, so it can't attach itself to the CD4 receptor, or it makes it unable to engage these CXCR4 and CCR5, these co-receptors. So these are interfering right in here. And then we have the entry inhibitors, and entry inhibitors The chemokine receptor antagonists, so the CCR5 antagonists, so those will block the co-receptors. Again, there's the co-receptors on the cell. So attachment's taken place, but the HIV, because it can't engage with these two co-receptors, it isn't able to enter the cell. So entry inhibitors can also inhibit the HIV from entering the cell. So the virus has to fuse with the CD4 cell to enter and inject its viral material into the cell, and so it can interfere with this process. The NNRTIs will bind to the reverse transcriptase right here. Remember, we need that to turn this single-strand RNA into DNA, so it makes it unable to do that. There's quite a lot of those available. The NRTIs modifies the action of the reverse transcriptase when it tries to convert the viral RNA into DNA. These medications will alter the development of the HIV's DNA, so the virus can't recreate itself. So it just messes directly with the virus's DNA. And again, there's quite a few of those too. The integrase inhibitors, so remember the integrase here is the enzyme that allows the DNA to integrate into the helper T cells DNA. So we need this for the virus to be able to take over the cell. And so integrase inhibitors, we have to have integrase to do that, and this inhibits that enzyme. The protease inhibitors will stop the enzyme protease from making those, from cutting those long chains of the virus. So I'm not sure I mentioned this, but those long chains of the virus that actually will develop into the new virus and then bud out and pop off. If you can't shorten those chains, which is what the protease does, the virus can't mature. So the virus will stay immature and sort of render it unable to mature and replicate. So undetectable viral load does not mean the patient is cured. So even if the viral load is very low, they still have HIV, and so still need to implement preventive measures, and the meds need to still be taken. Teach your patients that the meds have to be taken exactly as prescribed, because the HIV virus has the ability to figure out how to work around the medication, so it will change enough to, not be effective. And by taking the medications as prescribed, the viral load will stay low and prevent the resistance. So you want to make sure they're taking it consistently. Consider healthcare access and funding. Most people can get ARTs without, they're available. But if your patient has HIV or AIDS and is not on medications, then you want to ask them why not. There are drug-drug interactions, and so you'll want to do, whenever those patients get these prescriptions, you do a drug interaction check, but also ask about over-the-counter medications and herbal supplements. And one in particular is St. John's wort, which will decrease the effectiveness of some of these ARTs. A couple more slides. So pre-exposure prophylaxis, also called PrEP. This prevents the person from becoming infected with HIV. So if I'm someone who engages in high-risk activities, I know I engage in high-risk activities, I don't want to get HIV, and I test negative, I can opt for pre-exposure prophylaxis. So there's better outcomes when these are used in those who have sexual contact compared to those who are injecting drugs, but they can be used for anyone with high-risk exposure. And there are a couple of approved medications. They're combination medications, so Truvada is a combination of 2, Descovy is a combination of 2 also. Just different kinds of the tenofovir. And then they have to continue to take those pre-exposure medications. And I suppose they could stop them if they stop the high-risk exposure and continue to test negative. Post-exposure prophylaxis, so this is taken after a potential exposure to HIV, should be started within 72 hours. This is not for routine use, but for emergencies. So this would be used possibly like in cases of rape, or somebody who had just a terrible high-risk exposure, a healthcare worker possibly. Approved medications include, there's two, both combinations, and one of them, the Tivicay, is not used in pregnant patients. So that's all I'm going to say about the PrEP and the pre and post exposure prophylaxis, but just know that they are there and available, and just because your patient is on an ARV, it might not be because they have an active infection. They may just be taking it as a prophylactic measure. All right, so your assignment is to make a drug table to use as a study guide. So just list, pick out a drug from each category of each classification, and write down its mechanism of action, how it's given. Some are PO, some are subcutaneous, and your primary adverse effects and any nursing considerations. And that's all I have. Have a great evening.